So our last but not least speaker is Dr. Zardasht Oqab, a fourth-year adult cardiology resident. And Zardasht's mentor is Dr. Bob Sheldon. Zardasht is going to talk to us about distinguishing aging from frailty to help us prevent strokes in my neighbor who has atrial fibrillation, the Unfrail Atrial Fibrillation program. And I'm told he wants some chairs on the stage.
Okay, so I'd like to start by introducing you to my neighbor, Frank. He's a pleasant 80-year-old gentleman who's a retired teacher. He has hypertension, diabetes. He's had a TIA 6 months ago, and he's had some mechanical falls in the past and a history of an ulcer. Now, Frank is a very active guy. He's, in fact, his level of activity probably puts some of us cardiology fellows in shame. But he has a dog named Max, and he tends to walk it several kilometers a day, and without any active symptoms. Unfortunately for Frank, recently he's had some misfortunes. He was diagnosed with new atrial fibrillation, and his family physician is unsure what to do with him with regards to his management. Now, atrial fibrillation is the most common cardiac arrhythmia that is prevalent in the elderly. It is associated with a fourfold increase in the risk of ischemic strokes, and stroke prevention using oral anticoagulants such as vitamin K antagonist warfarin or the non-vitamin K antagonists, the No-OACs for short, is the mainstay of management. Now, as good as these drugs are in terms of preventing strokes, they do come with their own side effects of increased bleeding risks. And we don't actually know what to do with the very elderly, as the large phase 3 trials had a small proportion of the very elderly in them. So you can imagine yourself being the primary care physician of Frank and having these difficulties in terms of, do I put him on an anticoagulant or not? And this problem is going to become increasingly prevalent as our population is aging. Which comes to my next point, is that one of the biggest challenges that we're facing in the next decade or even now is of an aging population. In fact, the Statistics Canada predicts that elderly over the age of 65 over the next few decades is set to increase quite dramatically. Compared to 2005, by 2030, by 2030, 1 in 4 elderly will be over the age of 65. Now, this should be a haunting statistics for the clinicians, as our current healthcare system is not equipped to handle the problems of the very elderly. In a recent poll, 1 in 4 Canadians believe that, or think that there's not enough home care or nursing care facilities available for their loved ones who are very elderly. And 1 in 3 actually believe that there's enough hospital beds available to even meet the basic needs of the elderly in the community. And when it comes to why it's important for us in the cardiology world, is that the prevalence of atrial fibrillation increases quite dramatically with aging, with the elderly folks being at highest risk of developing it. And so we have these new drugs, the No-OACs. We know how to manage atrial fibrillation, but the biggest problem that arises from it is that the elderly folks are actually not receiving anticoagulants. When we look at across all the studies that have looked at anticoagulating the elderly with AFib, we find that on average about 50% of those who should be on an anticoagulant are receiving anticoagulations with no contraindications to them. And this is a big problem. And so we have to think to ourselves next, then why are only 50% receiving anticoagulation? And could it be due to a misperception on the part of physicians of frailty? So before I go into what frailty actually is, I'm going to ask an audience member to actually come up and help me with the next part of my presentation. And this is going to entail a very demanding, physically grueling test of whether or not to see if you're frail or not. So should I pick, or is someone going to volunteer? How about yourself in the front row? All right. So while my friend here stretches and warms up, I'll talk to you guys about frailty. So, aging. Do we all age the same, or do some of us age more poorly? So, aging and frailty are not synonymous. And frailty is defined as a biological syndrome of decreased reserve and resistance to stressors due to an accumulation of multiple defects throughout the years. There are at least two proposed mechanisms, one of which is an increase in the inflammatory cells and a decrease in the androgen production, which leads to a decreased muscle mass. And the second one is an accumulation of defect model of aging, of long-term wear and tear in the different organ systems, leading to the frailty phenotype, which is characterized by being slow, by being weak, and also just having a lower resistance to the stressors. And so there are over 20 frailty instruments that exist. Some of them require a specialist to actually deliver them, like a geriatrician. Some of them require specialized equipment, such as a dynamometer for grip strength. And they can take from anywhere from 5 minutes to deliver to over 3 hours. So you can imagine yourself in a primary care physician's office that depends on the volume of patients, that may not be the most practical thing. However, there are in existence other more simpler screening tests that we can do, which one of them I will demonstrate now. So Payam here, my volunteer, is going to do what's known as a gait speed test. And you'll see how difficult it actually is. So what I'll do is I'm going to time you, and we're going to test your speed. And that's supposed to be 3 meters, which kind of looks about 3 meters. So you can go ahead and start when you go. Okay. And that's it. And that's all it took. Even though he barely made it across, he is not frail. Now, you could imagine yourself, though, that if you were somebody who was elderly, if that distance took you longer than 6 seconds to accomplish, you would be at a higher risk of frailty, and then we would want you to do a more comprehensive frailty assessment. So please give him a round of applause for participating. Thanks, Payam. Now, frailty comes with actual outcomes. So in multiple studies, frailty was found, folks who are frail have been found to have more hospitalizations, worsening disability, being admitted to the nursing homes, having more falls, and even having a mortality, worsening mortality. However, we largely think that frailty is being overestimated in the community because of its subjective measurement of a primary care physician just seeing an elderly folk in front of them and thinking that maybe they're a bit more frail than they are. In a study that was done over 64,000 community-dwelling adults, the prevalence of frailty was found to be only 1 in 4 in patients who are over the age of 85. And that tells you that 3 out of 4 elderly over 85 are not frail. Now let's look at it a different way. So this is a graph that I made myself where I've superimposed in blue the prevalence of frailty, and in red is the inverse of receiving anticoagulation, so no anticoagulation. And what you can see is that there's a large gap that exists between the prevalence of frailty and not receiving anticoagulation. And that's a pretty large gap, and this is the focus of my study, where we actually are trying to narrow this gap. Though there could be many other reasons for why that gap is that large, we think that frailty plays an important role in that gap. And it's also very important because there are currently no guidelines to tell the family physician on what to do about Frank's issue. He doesn't want a disabling stroke, and he's quite afraid of having a disabling stroke because he's still 80, he's very functional, he's got a zest for life, and he's got things that he wants to cross off his bucket list. So for a primary care physician, it becomes very challenging to actually figure out in terms of his atrial fibrillation management. So we have a problem. And we have a paradox in the management of atrial fibrillation. We know that the prevalence of frailty is the highest in the very elderly, but the rates of anticoagulation is the lowest in them. But is it really a problem, or is it a big opportunity for us? And so this is where I'd like to introduce our program, which is called the Unfrail AF program. The Unfrail AF program is headed out of the Libin Institute, and it's a multi-phase study that looks to better understand frailty and atrial fibrillation relationship. The ultimate goal of the project is to answer the question, does objective measurement of frailty using a validated instrument increase the rates of anticoagulation in the elderly? The project is divided into multiple phases. We've already completed a few of the phases that you see up there. We've done a systematic review and meta-analysis of all the literature that exists in the field, which we shrunk it down to 4 studies that actually have looked at this particular issue. So there's a huge paucity of data in this field. We found that the prevalence of atrial fibrillation is 30% to 50% in this 900 or so patients population that we saw. We also found that being frail is associated with not receiving anticoagulation. There's an inverse relationship between frailty and not receiving anticoagulation. Currently, we're working on our next 2 phases simultaneously, where we're studying to see whether family physicians are actually measuring frailty, what instruments are they using, and what knowledge do they derive from those instruments, and how do they actually apply that knowledge to their clinical practice, and whether or not it actually will change their practice, knowing the frailty status of the patient. We're hoping once we're actually able to complete all of these things, we can actually do a randomized control trial to actually be the first in country and even actually in North America or anywhere else to do a prospective study. Because all of these have been retrospective studies, and we would be the first ones to do a randomized control trial looking at it in a prospective sense. I think that this is an important issue for clinicians that are here, or even any care provider that's involved with the care of the very elderly. And I think that we should all become familiar with at least one of the frailty instruments, because the next time you see Frank in your office, you'll know exactly what to do. So thank you, and I'll leave you with that.
Thank you very much, Zardasht. That was excellent. So we'll open it up for questions.
You suggested that primary care providers are overestimating frailty, and implicit in that is kind of the assumption that if you are frail, that maybe you shouldn't be anticoagulating. Is there any evidence to suggest that we shouldn't be anticoagulating frail patients with atrial fibrillation?
Yeah.
Why is that a determiner of who should be or who shouldn't be anticoagulating?
Yeah. Thank you for your question. So to answer your first question in terms of the overestimation, there has been a number of studies that have done on surveying the primary care physicians and seeing what factors actually deter them from anticoagulation. And they found things like cognitive impairment, falls, increased risk, increased comorbidities, and these things actually deter them from it. And they have found that when they've looked at it, when they see the patients, it's a subjective assessment, that these tools that we have for frailty assessments are not in clinical practice. So we think that they are being overestimated in terms of a subjective assessment. For your second part of the question, what we're focusing about is not so much to see what happens when you anticoagulate the frail elderly, because we know that the outcomes for the frail elderly are not good. In terms of their outcomes, they have, in 6 months, they have 20% or 30% mortality risk. But what we're wanting to focus on is the opposite of that. We want to make sure that the folks who are not frail are not being classified as frail and omitting them from receiving the anticoagulation. So it's a bit of it's different. And I think someone should look at the frail patients whether or not they should get anticoagulated, but that's not the focus of our project.
Thank you, Zardasht.